have a nociceptors, except the hair and the intervertebral disc, because the intervertebral disc is not having, it is an aneural and avascular structure. Even the hair, the root of the, until unless the root of the hair, remaining part of the hair, so there is no nerve supply, so we don't get a nociceptor. So everywhere we have nociceptors, and any mechanical deformations that cause depolarizations of the free nerve ending, okay, followed by that the mechanical pain has been originated. So the mechanical deformation that occurs by the mechanical forces, and definitely this is an intermittent type of pain. The pain responds the movement or the position, particularly the position or the movement, which can able to cause the mechanical deformation of the tissue, followed by there is a mechanical pain originating. So that will be relieved by the mechanical therapy. Say for example, like when you push your fingers backward, so there is a stretch pain will occur. So this is a mechanical pain. So how long this pain will be continued? How long I can able to maintain the forces, mechanical forces, moving the finger backward. So till that the mechanical pain, the stretch pain will be there. Once the mechanical force relieved, immediately next second the pain also will be relieved. So this is what the mechanical pain. So the mechanical pain can be relieved by the mechanical therapy, where there is a compressions, if there is a excessive depolarization of the free nerve endings of mechanical soft tissues. So the mechanical disturbances occurs, so the pain will be continued. Once the disturbances are relieved, automatically pain will be relieved. So what are the mechanical deformation? There are four kind of forces can be able to cause. One is normal stress applied to the normal tissue. That tissue is itself normal tissue. There is nothing, no problem is there. So tissue is absolutely normal. So when you apply the normal stress applied to that tissue, will have a definitely that will produce a pain immediately. Okay, so that pain also will be tolerable because this is normal stress only. Then there is abnormal stress applied to the normal tissue. The tissue is normal and you are applying the abnormal stress, definitely that can able to cause the damages of the soft tissue. So the soft tissue can be damaged. You say, for example, when you've been very strongly pinched and given a prick, so which can able to cause the kind of redness, and even the skin and soft tissue will be damaged. Okay, so this occurs in the postural pain, and there is a normal stress applied to the abnormal tissue. So the tissue itself abnormal. When you apply the normal stress, when you apply the normal stress to the abnormal tissue, definitely that causes pain because the tissue is abnormal. Even if you apply the very, very gentle normal stress also, which can able to produce a pain. Say for example, the patient who have the severe pain and the kind of disturbances there in the soft tissue, so the tissue is definitely abnormal. Even if you blow over the skin also, that also can able to cause a pain because the tissue is abnormal. So the abnormal stress applied to the abnormal tissue, 100%. So even the normal stress itself, the patient is not allow you to apply it on the abnormal tissue, and definitely abnormal stress will be applied to the abnormal stress is on the abnormal tissue, which can able to cause the severe intolerable pain. So we'll see about what is chemical pain. The chemical pain is inflammation and the infections. So the inflammatory signs will be present. So chemical substances like inflammatory fluids, all the things which can able to stimulate the free nerve endings of the nociceptors, followed by that the pain originating. So the pain is being stimulated. Okay, it has been originated by the chemical substances, not the mechanical deformations. So there is no change of the pain. Here, continuously the inflammatory fluid will be present on the nociceptors. So nociceptors will be continuously stimulated, and the pain will be continuous. But mechanical pain is intermittent one. So when you apply the mechanical pressures, pain will be there. When you don't apply the mechanical forces, pain will not be there. But here and definitely this will be relieved by the chemical therapy only. The chemical pain, when the patient who have the kind of inflammatory joints, say for example ankylosing spondylitis. So those people, if there is an inflammation, if it has been present active, at that time the mechanical therapy applicable is definitely contraindicated. So we'll see what is traumatic pain. Traumatic pain is a pain during and followed by the injury. At the time of injury, when you're going to get hit your hand on the somewhere else in the strong area, I mean wall or something, at the time of the hit, you get an injury. That is called traumatic pain. Followed by the traumatic pain, what happening on the tissue is going to the inflammation. So in the tissues will get injured. Okay, the tissues get injured. Followed by the injury, that inflammation starts. Okay, so that's damaging the soft tissue. At the time of the damaging the soft tissue, it's a mechanical deformation. Because of mechanical deformation or injuring the tissue, so the pain has been starting. So that is a mechanical pain. Once a mechanical pain is, injury has been occurred, later part it switch on to the chemical pain. That's the inflammation pain. So the mechanical therapy, like the positioning, that kind of strapping immediately that after injury, so that may reduce the severity of the mechanical pain, because the tissue is injured. Once you've been positioned and giving the support and strap, so which will be reduce the severity of that, but still the pain will be present. So that will reduce the severity, but that will not be completely abolish the pain. But once you switch on to the chemical pain, so after that time also, when you apply this all mechanical therapy, all the thing, so that will not have much role over that. Okay, now we'll see about the pain history. So what is a pain history? Before that, we have to see these all the history taking, pain history. Name, age, sex, occupation, address, this all the thing will be the general patient profile. Then where is the pain, present pain is being felt? Okay, whether the pain is in the central, or it is in the bilateral, or it's in the unilateral one side origin. How long has the pain been present? Whether it's the acute pain or it's in the vigorous, it's in the chronic pain. Okay, how long? The time period of the pain. And how did the pain commence? The patient will explain about that. Is the pain is a constant or intermittent? Based on that, we can detect whether the pain is in the mechanical pain or it's in the chemical pain. And what makes the pain worse or better? So shortly called as aggravating factor and relieving factor. If something else you do, the pain will be aggravated. Something else you do, pain will be released or will be nil. So that kind of history how to collect from the patient. Have there been previous any episodes of low back pain? Previously, the patient have got some kind of low back pain, then you would have taken the treatment and relief. Again, the pain would have been recurrence. So that also has to be checked. And other further clarifications, like pain on the cough or sneezing during the, when the patient cough, sometimes the patient will say, when I cough, I'm getting like a shock type of pain, which will be starting from my back and coming down. Sometimes the patient will say, when I sneeze, I'll get a pain from here, neck, and it comes down. It's like a shock type of thing I'll feel. So whether the cough or sneeze, during the cough or sneeze, the intra-abdominal pressures will be increased, which can able to increase the intradiscal pressure. So if the disc comes out and pinch the nerve roots, so whenever the disc pressure is increased and comes out and apply the pressure on the nerve roots, so all the time the kind of shock type of pain patient will get it. Any sleep disturbances, the pain or the pain on arising early morning. When patient will say throughout day I don't have pain, morning when I get up I got a very severe pain. So definitely this gives certain information that we are going to see in detail about that. Any reason weight loss, it may give the patient who have a spine problem, who have the TB spine, but the patient are not known, not been tested. So maybe, but the patient gives some kind of clues. There is a reason weight loss. So we can able to suspect. Then we can ask the patient to go for the medical clarifications. Any major other surgeries like any abdominal surgeries, thoracic surgeries, any cardiac surgeries, any other things have been surgery has been done recently, 6 months back, 1 year back. So followed by that, the muscle become weak. That also can cause some pain. There's saddle anesthesia, the bladder control. Yes, if the patient is reported, is there any saddle anesthesia on the sacrum region? There is anesthesia. So that also will give a clue of the compression of the sacral nerve root. So these are the general first pain history. Now we'll see about in detail about the pain assessment. Again, I'm very grateful this pain assessment, each and every part of the pain assessment, it taught and nicely given prick or pinch by my professor, Dr. A.G. Dandamani sir. He taught me each and everything, what is the meaning of that, why you should be take care about each and everything. He has been taught very, very clearly. What he taught in that only, I'm just continuing for that. So the pain assessment that onset, there is a 12 things are there. I can able to tell about very shortly. Onset, site to site, type, duration, character, aggravating, relieving factor, 24 hours pattern, severity, irritability, nature. This is what the 12 criteria of pain assessment. What is that? Onset, how the pain originated. Whether the patient will say, sir, I had a fall, followed by that I got a pain. So the pain started sudden onset. So there is a sudden onset. If there is a fall, followed by the fall, pain started, that definitely that is sudden onset. Another patient will say, no, I don't have any fall, but gradually I was getting the pain. One day I got a pain little bit, I just ignored. Then every day by day I'm getting pain more. Now it has become worse. So it is a gradual onset. It is not a sudden onset. So there is a gradual onset of the pain. So the mechanical deformation can occur suddenly one day followed by the fall. There is a trauma, the mechanical deformations. So followed by that also the pain will have been originated. Or there is a gradual onset. Gradually the mechanical deformation occurred because of the wrong posture, positioning, okay, any strain, etc., etc. These all the things can able to cause. So this is what the onset, whether the pain started suddenly or it's a gradually. First, that information we need to be get it. Second one, what is the site of the pain? So site means many times they'll say, sir, I have a pain on the shoulder, like that. So it is not like that. Site means exactly anatomical landmark. Anatomical landmark, anterolaterally, or exactly anterior aspect of the shoulder on the joint line, anterior aspect of the shoulder on the bicipital groove, or anterolateral aspect of the shoulder on exactly on the acromion process or acromio-clavicular joint. So that's what the landmark. That's what that which will be specify the location of the pain exactly. So many times it has been told by many of the students and physio. So where is the site of the pain? It is in the lumbar spine. Lumbar spine is a very vast area. Lumbar spine. In the lumbar spine, where exactly it is there? Whether it is in the L4, the transverse process area in the right side, or in the center, it's in the spinous area, or it is where exactly it is there. So that's what the site. When you apply the pressure, we'll come to know that there is a landmark. This is what the tenderness. What we say. Here is the pain. No. Here is the pain. Yes. So what is the meaning of the pain here? Okay. What is the meaning? The pain here is not there. So what structures are there here and no pain? So the structures are, there is not a problem. Here, yes, there is a pain. So it means, so what are the structures are underlying this point that may be the problematic. So this is what the site of the pain has to be find it out clearly, pinpoint. The next we have to go for the side of the pain. Which side the pain is in the right side or on the left side? Sometimes patient says, sir, I get a pain on this completely outside here. Okay, or the patient says, I have only pain on the center only. It is not on the right side or left side. It is on the center area. So the side of the pain, the site, exact location of the anatomical landmark. Next one is the side of the pain. Next is the type of the pain. Always the type of the pain, we should not give any clue to the patient. Sir, how the pain do you feel, sir? Is it like a zoom type of pain or pulling type of pain or something like you have a pain something differently? So patient, yes sir, I feel like pulling type of pain. So the patient will just easily, the patient will follow. So what is the type of the pain means that should be described by the patient's word. Patient should explain. So what is the pain, the type of the pain. So we'll ask the patient, sir, please explain about your own words. How do you feel the pain? Just explain. The patient will explain in the one paragraph. He will explain. Sir, I'm getting the pain here. It is from here. It is starting just like a pricking type of pain. It is coming here. Still here it is coming, sir. So if we give a blank page to the patient will explain detailedly, thoroughly. But many times the clinicians will not have the patient to listen the patient's word. So we'll give a blank page, blank. We'll have enough time to describe about the type of the pain. So next one is a duration of the pain. So what do you mean duration of the pain? It is nothing but like the age of pain. How long the pain is there? Whether the pain is, from yesterday evening onwards, the pain is there. So this is short, only 24 hours. Definitely the pain is acute pain. So the pain is only one day. So the pain started yesterday. So yesterday the pain born. So today it's 24 hours. So this is what the age of the pain. Duration of the pain, or it's called age of the pain. So if acute pain, right? So what you should do? Why we have to collect this all information? What we should do? We need to collect this all the information there. All right. So if the patient is telling, sir, since 3 months the pain is there, continuously 3 months on and off, sometime will come, sometime will more, that, everything, but 3 months I'm getting pain. So the duration of the pain is 3 months. So definitely this is not an acute, it's subacute, or in the chronic state. So the duration of the pain, if it is the pain is acute, then we have to give the manual therapy, the treatment, mobilization, all the thing, very, very precautionary things. If the duration of the pain is prolonged, it's in the chronic pain. So even you can give a little bit of vigorous manual therapy, because the soft tissue surrounding that joints and the painful structures, everything will gone for there is an adjacent apposition, there is an adaptive shortening occur. So to release all the adaptive shortening, I think we can give the vigorous manual therapy. But the vigorous manual therapy it should not be applied to the patient who have the short duration of the pain. It's in the acute stage. Acute pain, we should not give the vigorous and very, very gentle manual therapy. Next one, character of the pain. Already I told you the character of the pain. There is two characters. One is a continuous and another is a intermittent pain. So continuous character of the pain, we already seen. It is in the chemical pain. Intermittent pain that occurs on the mechanical pain. So aggravating factors. So what are the movements, what are the activities which can cause you get a more pain? So that is what aggravating pain. Patient will say sometime, sir, when I stand, I'm getting pain. Okay. Any other things will aggravate pain. When I sit without backrest, I'm getting pain more. So with support, not pain. Okay. If you walk, no pain. When you sleep, no pain. So whenever other times, what are the activities can able to increase the pain? Sometimes resting also can aggravate the pain. Sir, when I keep on walk and roaming around that, so I don't get any pain. But once I come and lie down my bed, horrible. I'm getting more pain. So the aggravating factor means any movements only can cause a pain. No. Even sometimes rest also can aggravate the pain. So that's what aggravating factors. Whether the rest or particular the position or any particular the movements, whichever things is aggravating the factor, everything can be listed out. Relieving factor, same like that. Whichever the factors can be able to relieve. But many times it has been wrongly thought. Relieving factor means when you get a rest, you don't have a pain. No. Why not? Sometimes rest also can aggravate the pain. Sometimes movements will relieve the pain. When you move, when you walk, when you do the flexion, lumbar flexion, the pain would have relief. So the relieving factors means it's not absolutely rest alone. Even there are certain movements also can relieve the pain. Next, 24 hours pattern. 24 hours pattern. Yes, this point is very important. The 24 hours pattern in the full 24 hours, when the patient getting more pain. So you can ask to the patient. Sometimes the patient will say, sir, early morning, I'm getting severe pain. That is one thing. Morning when I get up, I'll get a pain. So afternoon time, when I do the work, I'll get a pain. When I end with my work, I'll get a more pain. Before go to the bed, I'll get a more pain. So midnight, I'll get a pain. So everything, the patient will complain that. The 24 hours, in which hour the patient getting more pain. In the early morning, or the morning, or the noon, or the afternoon, or evening, or the night, or midnight. So in this position, in this pattern, so when the patient get a more pain. So this is what the 24 hours pattern. Severity, we all knows about that severity of measure the pain assessment, the VAS, visual analog scale. So visual analog scale. So there is a scale. I before meet Dr. Dandapani sir, I was doing wrongly VAS score, and he is the one who corrected me, because the visual analog score, the scale, it's a plane. There is a line, 10 centimeter. The line, that's it. That line is 10 centimeter. I only should know. So I have to explain to the patient, sir, this is the line. Look at this. This end, the line has a two end. This one end has no pain, absolutely no pain, zero, no pain. Don't give the numbers also, no pain. This end has severe pain, intolerable severe pain. So between this no pain to this severe intolerable pain, where you feel your pain is it, there you mark it. So patient will think about that. He will mark somewhere. If he will try to quantify himself the pain. Okay, how much the pain. So if he feel the pain is almost like 80% something, he may mark it near to that. Okay, from maximum intolerable pain is 100 means, so from there to here. So he'll mark it. But one thing is, we should not tell to the patient what is the numbers. So this is 0, this is 100. No, that is called numerical rating scale. That is called numerical rating scale. That is not a visual analog scale. But many times the visual analog scale has been wrongly practicing when we deal with the patient. Visual analog scale is only visually. Visually, patients should see that line, this end, that's it. No more clues, no more numbers. Sir, it is a no pain, severe intolerable pain. That's it. Only this things. So in between, where the patient feel he is that much pain, let him mark. Once he marked it, you can take the scale and again you can measure where the patient marked it. Okay, it is a 10 centimeter pain, it's a 100 millimeter. So it is a millimeter. So only in this millimeter, the calculations only this. So this is what visual analog scale. If anybody is given this is 0 sir, this is 100 sir, like this, it is a numerical rating scale. So patient will feel that, oh, this is 100, okay, I am getting 60. So he may mark it. So it is a numerical rating scale. So that is that is also the methods. But the numerical rating scale, patient will stick with the numbers. He will not stick with the pain. The patient will not try to quantify how much pain he has. That patient will not stick with that. He will stick with the numbers. Okay, this is a number. Another thing is that one more psychology, patient psychology. If I give a little bit of more number, so doctor will give a very good treatment. My pain would have relieved very early. So that calculation also patient may do that. So always no clues. Blankly ask the patient question. That's it. So patient will give a reply according to what he is giving the reply, that answer. Based on that, we have to do the interpretation. We should not allow the patient to take a clue something and let him do the interpretation. No, not that. So it's a blank question and let the patient answer. Then whatever the answering patient do, everything you have to collect and we have to interpret. So that's what the severity. Here, visual analog scale. Next one, irritability. So what is irritability? Irritability is many times many of the students, when I ask, they will say, sir, how the patient is irritating the pain, so that we can able to mark it, sir. So not that one, irritability. Irritability is when particular the activity when patient do, for example, standing the patient get a more pain, right? So sitting is a relieving factor. So once a patient sit, okay, pain relief. The irritability means the pain will take what's the duration to relieve it. Once he come to the relieving factor, okay, resting is a relieving factor, means once the patient come to the resting factor, rest, sitting. So as soon as the sit, next second there is no pain. That is less irritability. As soon as the patient sit, it will take few seconds, okay, almost 10 seconds, take to relieve the pain completely. So that is moderate irritability. Once the patient reach the relieving factor, sitting, but it takes few minutes, 5 minutes, gradual pain is coming down. After 5 to 10 minutes later, no pain. So this is severe irritability. So it is a response of the tissue. We have to bother about the tissue, whether the tissue how nicely it is responded. When the tissue is there, when you give the kind of strain, particular the factors, when you give the things strain, pain is more. So when you give the comfortable relieving factor, so the tissue will be relaxing and relieving. So but it will take how much irritable the tissue, so that much time it will take to relieve the pain. So that is what the irritability. So the tissue irritable, okay. So the tissue damaged, the damaged tissue, the pressure is applied. Again and again, the mechanical deformation is there. So the pain is aggravating. So once the tissue comes to the comfortable position, so now pain is gradually relieving. Sometimes if it is a little bit of damage, little comfortable, immediately that pain will be relieved. If the damage is a little more, it will take few seconds to relieve it. If the damage is some more, even if you give a comfortable situation factor also, it takes some more minutes to relieve completely. So this is what the irritability. So how much? If the patient say, no sir, once I sit, there is no pain while sitting, but once I sit, immediately the pain is not relieving. It will take almost 5 minutes. After 5 minutes of sitting, no pain. So this is severe irritability. So the severe irritability patient, we should deal very carefully. And less irritability patient, as soon as I sit, immediately next second, no pains are. Less irritability. So the less irritability patients, yes, we can use the vigorous manual therapy. Next, nature of the pain. So nature of the pain, there is two nature. One is mechanical nature, another is chemical nature. Based on these all the things assessment, we can come to know that whether the pain is in the mechanical nature or it's in the chemical nature. Mechanical nature is a mechanical pain. We can come to know that it's a mechanical pain. So that will be relieved by the mechanical. So there is a shortening of the tissues. Okay, there is a kind of derangements. So anything. So these all the things can be solved by the mechanical. So we can able to give the proper mobilization. Okay, proper grades of mobilization we can decide it, and that one we can able to apply to that. So this is what the treatment plan. So before go to the treatment plan, we have to come to the conclusion of the pain, whether this pain is common for mechanical pain. Then the patient is the eligibility to get a manual therapy. No, it is not a mechanical therapy, mechanical pain. This is chemical pain. Okay, there is a severe inflammation and all is here. Okay, patient said aggravating factor is a movement, and aggravating factor is rest, and relieving factor is a movement. So definitely this is chemical pain, because the patient who have the inflammation, while they're taking rest or at the end of the rest, they'll get a severe pain. So it means there is a chemical origin. So pain is chemical origin. That's what the nature of the pain. So this is what the 12 criteria we are supposed to assess in the pain assessment. I repeat: onset, site, type, duration, character, aggravating factor, relieving factor, 24 hours pattern, severity, irritability, nature. So this is what the pain assessment is supposed to assess. Next part, now we'll come to the part is articular neurology. So this is what is articular neurology. This is mechanoreceptors. Yes, there are so many types of receptors: type 1, 2, and 3, 4. So there are receptors. We'll see the type 1 receptors. The type 1 receptors, it's a thinly encapsulated, this globular corpuscles, okay, and there is a tridimensional clusters, 3 to 8 corpuscles. So this is what the morphology of the type 1. Where it is located? It's located on the fibrous capsules of the joints, superficial layers. All the joint has fibrous capsules. The capsule, on the capsule superficial layer, this type 1 receptor located. And this nerve, this receptor has a link with the parent nerve fibers. This is small myelinated fibers, 6 to 9 micron meter. And what is the behavior? The type 1 receptors. So this is a static and dynamic mechanoreceptors. So this is low threshold and slowly adapting. So when you give the kind of low threshold mobilization, so that time this type 1 receptors will be stimulated. Okay, so this is what static and dynamic mechanoreceptors. Next, we'll see about type 2 receptors. So the type 2 receptor, this is thickly encapsulated. This is conical corpuscles. Okay, the dimensions is here 280 micrometer, 120 micrometer, and individual are in clusters of 2 to 4 corpuscles. So it is a thickly encapsulated. Where it is located? This also located same fibrous capsules of the joint, but it is not there no superficial layer. It is a deeper subsynovial layers, and even articular fat pads also. This is located. Type 2 receptor located articular fat pads also. And this connected with the parent nerve fiber is medium myelinated. Okay, so medium myelinated nerve fiber, it has a link. So what is the characters? This is a dynamic mechanoreceptors. Dynamic mechanoreceptors, low threshold, and it's a rapidly adapting. So it is a low threshold and rapidly adapting. So type 1 is a low threshold and slowly adapting. This one also low threshold, but this is fastly it is adapting. It's a type 2. So this is what the articular neurology 2, type 2 we have seen. Now we'll see type 3. This is thinly encapsulated. The corpuscles shape is a fusiform. So fusiform corpuscles 600 micrometer into 120 micrometer. So individual are in a clusters 2 to 3 corpuscles. So this is what the corpuscles here. And what is the location? So where is the location here? The type 3. This applied to surfaces of joint ligaments. So the ligaments which connect the bones near to the joints. Okay, the ligament, what are the ligaments are there? So on the ligaments, over the ligaments, the type 3 will be located, especially like a collateral and intrinsic ligaments. Intrinsic ligaments, also the type 3 mechanoreceptors will be located. And this is a large myelinator fibers. Okay, this have a parent nerve fiber. Parent nerve fiber is large myelinator. Okay, 13 to 17 micrometer. So what is the characters? It's a dynamic mechanoreceptors, but this is high threshold and slowly adapting. High threshold and slowly adapting. Type 1 and 2 only is a low threshold. Okay, and type 1 is a low threshold, slowly adapting. 2 is a low threshold, rapidly adapting. Type 3, this is a high threshold and slowly adapting. This is what the type 3. Now we'll see about 4. Type 4. So it is a tridimensional plexus of unmyelinated nerve fiber. This is tridimensional plexus of unmyelinated nerve fiber. So this is 2 parts underlaid. So type 4. We have A, it's a tridimensional plexus, unmyelinated fiber, nerve fiber, and there is a free unmyelinated nerve endings. Free unmyelinated nerve ending. So this is what the 4. Where it is located? In the type 4A, it's located fibrous capsules of the joint, articular fat pads, and adventitious sheets of articular blood vessel which is passing in the joints. That even when you do the stretch, not only the muscles and ligaments will stretch, even the blood vessel, the nose which is passing through the joint, everything will get stretched. So if it gets stretched, articular blood vessels, from there also the stretch receptors will be located, the type 4A. So that will send a information to the brain, I'm getting pain. So that also will cause a pain. So next, it's a parent nerve fiber is type 4A is a very small myelinator. It's a 2 to 5 micrometer, and unmyelinated it's less than 2 micrometer. Where it is located? The nociceptive mechanoreceptor is a very high threshold and it is non-adaptive. Very high threshold. It will not adapt, definitely. And 4B, and it is a free unmyelinated nerve fiber. Where it's located? It's located the joint ligaments, collateral and intrinsic ligaments. So both the 4A and B is it's a very small myelinator fibers. And 4B, it is a chemosensitive. 4B is a chemosensitive to abnormal tissue metabolites and nociceptive receptors. So it's a chemosensitive. 4B only is a chemosensitive. Remain all the things is a mechanoreceptors. So this is what the articular neurology. So if it has been given like a corticosteroid, all the injections have been given. So definitely that will work it on the 4B because that is a chemosensitive. So through that also chemosensitive 4B receptors have been keeping quiet, and followed by that pain also will be reducing. Remaining all the things, type 1, 2, 3, and 4A, everything is a mechanoreceptors. This is what the articular neurology part. Now we'll see about this mechanoreceptors. This mechanoreceptor, what is the effect? How the manual therapy giving the mechanoreceptors, through the mechanoreceptor we can able to reduce the pain. So there is effects. There is a central effects of articular mechanoreceptors. So what are the effects? There is a reflexogenic effects. Reflexogenic effects, articular mechanoreceptors, this exert reciprocally coordinated reflexogenic influences of the muscle tone. If when I give the manual therapy, mobilization, so definitely the manual therapy I'm giving, the mobilization giving to the joint. So what are the muscles surrounding the joint? The muscle tone reflexively it is altered. It has been reducing it. The manual therapy thinks it can able to the mechanoreceptor, because I'm operating the mechanoreceptors. As the mechanoreceptor keeping quiet, these are reflex effects taking place through the influence in the muscle tone. So muscle tone is been reducing. Definitely the muscle tone is been reducing. The patient will get a less pain. So manipulation of the individual joint not only affects the muscle over the joint. Even here I am operating, there is a far area. Far, the muscles are located very far. So that also will be, it can able to affect on the remote muscles also. So not only of the working on the muscle joint being manipulated, but also in the more remote muscles also it can, the manipulation can able to do that. So manipulation give rise to the reflex changes in the muscle tone. Okay, if the joint is, there is a pain arising in the joint, okay, the mechanoreceptors are there. So surrounding the muscles, the muscles surrounding the joints definitely will not be the normal tone. So when I've been operating this mechanoreceptor keeping quiet, the pain is being reducing, definitely there is a relaxation will occur. So reflexively the muscle tone surrounding the joints will be reducing. Not only this muscles, even there is a remote muscles. Even if we operate on this cervical, even there is a thoracic region, the muscles also will be, muscle tone will be reduced. This is what the reflexogenic effects. What is the perceptual effects? So perceptual effects, type 1 mechanoreceptors, this contributes the perceptual experience of postural sensation and kinesthesia. So the type 1 mechanoreceptor, what we have seen now, there are 4 mechanoreceptors, and first 2 receptors. Low threshold, slowly adapting. This is type 1. That mechanoreceptor is responsible for postural sensation. Even if I close the eyes also, if I bend my head, I can able to detect, okay, my cervical spine is bending. Okay, I even close the eyes, when you bend your elbow, I can able to bring to the 90-degree elbow flexion. Yes, I can able to bring to 90-degree elbow flexion. Right. So this is because of the type 1 mechanoreceptors. Type 1 mechanoreceptors, this will give the postural sensation. Even if I close my eyes and stand, I can able to stand erect. Okay. As soon as I close eyes, my body will not wobble. So if my body is wobbling, definitely there is a problem with mechanoreceptors, type 1. So there is a destruction of articular mechanoreceptors. This manifests impairment of the postural and the kinesthetic sensibility. So if there is mechanoreceptors has been damaged, if the mechanoreceptors of the spine is damaged, so when the patient come and stand or sit in upright posture, so definitely the patient will have a kind of postural imbalance, sensibility. So there is an impairment of the postural and kinesthetic sensibility. So next one is the pain suppressions. So the pain suppression is the mechanoreceptors stimulations by manipulations. So what are the mechanoreceptor locators? So by manipulation, I can able to stimulate the mechanoreceptors. That will produce a presynaptic inhibition of nociceptive afferent activity in the basal spinal nuclear neurons. So this is what we'll say about pain gauge. So when I give the manipulation to the mechanoreceptors, so the mechanoreceptors will be keeping quiet, followed by that the presynaptic inhibition. We know about that the synapse. So presynaptic inhibition will take place of the nociceptive afferent activity, because the pain is an afferent activity. This will take the pain from the distal to proximal towards the brain. It goes. So there's afferent activity, nociceptive afferent. So in that there is inhibitions. So there is a afferent activity, the pain signal carrying towards the basal nuclear neurons. So there it will be blocked and the pain pathway will be stopped. So patient will not get the pain. So this is what the pain suppression also will be done by the manual therapy manipulations. This is what the central effects of articular mechanoreceptors. Now we'll see about is there any relation of pain and the range of motion? Yes, absolutely. Patient will come to department. Sir, I have a shoulder pain, sir. I cannot. So when you check the patient, so only the range of motion will be lesser. Beyond that, if we try and the patient will get a more pain. Right. So what is the idea of the patient? Patient has come, sir, I have severe pain. Why the patient has come to the department? Whether because of the pain? No. The pain, it is coming and disturbing his ADL activities of daily living. In his daily activities, functional activities, the pain coming and disturbing. Because of that, the patient has come. Say, for example, the patient has a pain. The patient has a pain. The pain is not at all disturb his day-to-day activities, functional activities. Whether the patient will come to the physiotherapy department or whether the patient will go and meet any doctors means no, absolutely. Because he can able to do the functional activities well, no problem. The pain is not at all disturbing, but he get a pain. The pain is not at all, absolutely not disturbing the functional activities. Patient will never go to meet any doctors. So the pain and range of motion. The patient has come to the department not for the pain relief. The pain is disturbing on the functional activities. The range of motion 0 to 180 degree. So he is not able to do. He is bringing it to the 100 degree. There is the pain comes. So he cannot able to raise the shoulder beyond 100 degree. 180 degree is not reaching. That's what he is coming to do. So the pain and range of motion is interrelated. Pain and range of motion is interrelated. Okay. We'll see about what is movements. Okay. What are the types of the movement? There are two types of movements. One is physiological movements, accessory movements. So for manual therapy, I think this is a very basic one for that. So I'll be explaining a little detail. Physiological. What is physiological movements? Nothing but osteokinematic movements. Osteokinematic. Flexion, extension, abduction, adduction, internotation, everything is all physiological movements. Accessory movements. Accessory movements. This is orthokinematic movement, nothing but orthokinematic movement. There is a movement which will be taking place inside the joint. So inside the joint, so there is a joint, concavity, convexity, if it is there. So there is a joint. So inside the joint, the movements are taking. The movements occurring between the articular surface. So this is accessory movements. Physiological movements, flexion, extension, abduction, adduction. These are all the movements. Yes. Without accessory movements, there is no physiological movements. Say, for example, during the abduction of the shoulder, the humerus moving upward. So, how the humerus can able to move upward? Because the head of the humerus, which is a convex surface, which articulate over concave surface of the glenoid fossa. So, there is a gliding. There is an inferior gliding is taking place. There is an inferior gliding is taking place between head of the humerus and the glenoid fossa. Because of the inferiorly, the head of the humerus is being gliding. So that's the reason humerus can able to move upward. The head of the humerus can able to move gliding downward. Because of that, the abduction is taking place upward. So, without that downward movements of the joint and the between the articular surface, there will not be any physiological movements. So, to improve the physiological movements, patient is coming, sir, my abduction is this much, 100 degree. So, what you are supposed to do? You have to try to improve. Why the abduction is not coming? Because the gliding, the inferior gliding is stuck. The inferior gliding is stuck. The head of the humerus is not completely gliding over the glenoid fossa. So once that will be regained, automatically the abduction will become full range. Right. Next one, we'll see what is end range. One range is starting from here. definitely there is an end of the range. Yes. How many end range? There are two end range. One is physiological end range, another is anatomical end range. Physiological end range is tissue limitation. The physiological end range is limited by the tissue. The tissue approximate. When there is a tissue and tissue contact each other. Say for example, when there is elbow flexion. When there is an elbow flexion, the biceps curl, okay, the contour of the biceps is meeting on the contour of the flexus group of the forearm. So both will be come and contact each other, automatically elbow flexion end. This is physiological end field. Anatomical end field. But is it the correct end field? No. Even some more also it can go. How long? When the radius and ulna come and contact with the shaft of the humerus. Till that the flexion can continue. Like this, it can keep on, goes. When this is the radius and ulna come and contact on this humerus, the movement elbow flexion end anatomically. So that is what bony end field. So every range of motion, the starting range, there is an end range. There is a two end range. One is physiological end range, another is anatomical end range. So we have to bother about the physiological end range because all the functional activities will come and fall within this range. Okay, all the times in day-to-day life we don't force our shoulder, elbow completely flexion like this and that. We don't do that. Okay, the functional range end within that. Okay, if there is no pain and restriction within the boundary, even not on the boundary line also, if it is not there, so absolutely there is functional range of motion free. Okay. So what is the relation of the pain and range of motion here? This has been stated by the manual therapy concept. Never think about pain without think about range. Never think about range without think about pain. If you want to improve the range of motion, you have to think about the pain and you have to reduce the pain. Until unless if you don't reduce the pain, you can't improve the range. Ulta, if you want to reduce the pain, you have to improve the range. Without improving the range, you cannot reduce the pain. That's it. So this is what the main core concept, the pain and the range of motion. Only I want to reduce the pain. Not possible. You have to improve the range. By improving the range, only you can reduce the pain. I want to improve the range. Without reducing the pain, you can't improve the range. So this is what vice versa. So next one, what I'm going to say here is the concave convex rule. The concave convex rule, it has been explained by the Colton Bone. He is a forefather of all manual therapy concepts. Even there are so many other manual therapy concepts we are going to see in the next sessions. Colton Bone manual therapy concept, Maitland concept, McKenzie, Sree, Mulligan, David Butler. David Butler is entirely different. All author has been told, yeah, because of this structure, the problem only the movement is restricted. Okay, so we are going to improve the movements between the articular surface. Automatically, the movements will be improved. But David Butler told, why don't the peripheral now is one of the reason for the movement restriction. If there is a shortening, okay, all the authors has been told because of the adaptive shortening of the ligaments, adaptive shortening of the tendons, muscle, that everything, yes, movement is function. Yes, but nobody has been touched on the peripheral. He is the first and foremost one told even the peripheral nerves also can shrink. It also go for the adaptive shortening. So that's the reason David Butler told that there is a neural tension test. Neural tension test. Peripheral neural tension test. So each and every nerve has a tension. Even if you do the extension of the wrist, okay, everybody will say about there is a stretching of the muscles, tendon, ligaments, everything. Yes. Even there is a median nerve also passing over there. The median nerve also will stretch. Even the blood vessels also passing over there. Artery, veins, everything will get stretched. In that anterior structure, any one structure, if it is adamant not to stretch, you don't get a complete full range of motion. This is what the main concept of that manual therapy. we have to think about that everything, all the structure. If you want to be regain the complete range of motion, what are the structures are there? All the range of motion, all the structures has to be get a proper full elasticity, and you should get a full elastic range. So then the range will be complete. So David Butler is the one told even peripheral now also can able to limit the range of motion. So the first one, before go to all the thing, be clear about what is concave convex rule. So convexity and convexity and concave. So there is a concave and one convex. So this is what operating. So this is what concave convex rule. What does it say? When the convex surface moving, okay, the convex surface is moved. Okay, which direction? This is the direction of the bone movements. Okay, and this direction bone moves, and when the convex surface, this moves in the opposite direction. The gliding is taking place on the joint is in the opposite direction of the osteokinematic movement. Already I told you the example: shoulder abduction, humerus moving upward. So what is the shape of the head of the humerus? It is a convex surface. So when the humerus is moving, the convex surface of the humerus, it is gliding downward over the glenoid fossa. Glenoid fossa is a concave. So the convex surface is moving over the glenoid surface. It is in the downward, inferior gliding. Inferior gliding taking place. That's the reason the humerus can able to move upward. So opposite direction. Which direction the bone moving? Opposite direction. This surface moves. This is what the one. And if it is a concave moving, if the concave surface of the segment, that bone is moving, so that will be the same direction of the bone movement. Say for example, knee joint, the condyles of the tibia, it's at the concavity, and the femoral condyle is the convexity. So when you do the knee flexion, when you're sitting position, when you do the knee flexion, so that tibia moves posteriorly. Tibia moves posteriorly during knee flexion. Tibia moves posteriorly towards the posterior aspect of the thigh. So the concave part of the bone is moving. So the gliding also in the same direction of the movement. Which direction the movements are taking place? Posteriorly. Okay, the segment is moved posteriorly. So the gliding also will be there, posterior gliding. So this is what the concave. When there is a concave surface, when there is a the gliding will be in the same direction. When there is a convex surface moves, the gliding will be the opposite direction of the movement. So this is what the concave convex rule. Okay, so here I end my lecture, this part of the lecture. So if there is any questions, I'm very happy to listen. And thank you very much for listening lecture. Thank you.
Yeah, thank you, sir. It's really a wonderful session. So we have yes, Balaji sir, it's really a wonderful session. So we have discussed elaborately regarding the pain, the articular neurology, and the range of motion and the concave convex rule. So it is very essential while doing an assessment for a patient. I hope everybody has understood well, and they will be able to implement it on while they are going to assess a patient. So regarding sir, one question, sir, regarding the manipulation. What is the mobilization? Can we give the mobilization in acute stage? Manual therapy?
Yes.
Yeah.
Yes, of course, of course. That's what the duration of the pain. We have to see that. If the duration of the pain is been short, it's acute state. But we have to make sure, because many times that acute pain will come along with the inflammation. If there is an inflammation, inflammatory signs if it has been present, so that time we should avoid the manipulation. If there is no inflammation, only that there is a pain alone if it is it, so absolutely we can go for mobilization, manipulation we can go, but it should be very, very gentle manipulation we have to go, not a vigorous.
Okay.
If the condition has been chronic, if there is a chronic pain, of course we can go for the vigorous manipulation, because there is so many scar tissue will be formed around the joints, even the ligaments, elasticity, the tendons, everything. There is chronic pain, definitely the immobility will be there on the joint. So all the soft tissues surrounding the joints definitely will be the tough in nature. We can go for vigorous manipulation at chronic stage, but in acute stage, very, very, very gentle manipulation with the most precautionary things, action you have to take it and do that, and make sure there is no inflammation, no inflammatory signs present.
Yeah, okay, sir. Thank you very much, sir. And regarding the concave or convex rule, sir, is there the Butler mobilization and the Maitland mobilization? So how does it vary with that of the other mobilization? There is a question in the chat
Madam,
box.
every
Yeah.
concept is been varied.
Yeah.
We will see detail about the differentiation between one concept and the other concept next session in detail. I'll tell about what is the Maitland concept. Then I'll tell what is the McKenzie, what is the Mulligan concept, what is Syriax, what is every concept. Finally, when you come to the David Butler concept, there is a differentiation easy. So
Yes.
generally, I'll tell about the differentiation here. All the manual therapy concept, it has been concentrated about the articular surface, in and around the articular surface. So nobody think about beyond the articular surface and the muscles. Even there are some other structures also can able to limit the range. But David Butler is the one told, why don't the peripheral nerve also is one of the reason for the limiting the range. So, but he has a proof also. Even there is a movement, any movement, even there is a normal, there is a to and fro movements are there on the peripheral nerves. So that is called as a gliding. The gliding will take place in the peripheral nerves also. Even peripheral nerve also can be elongate. It can be stretchable. Even the blood vessels also can be stretchable. So this is what his concept is being told, David Butler. So that's called even his concept. The assessment and management both are same. So they will check the neural tension test. Once they have found, yes, the particular nerve is in the short end. So the same test will be repeatedly for almost 8 to 10 times. Automatically the nerve will be stretched and relaxed. So this is what the David Butler concept. Actually, the concept, everything has been very simple. Even I used to tell to my many of the students, until we don't catch the roots, we will not get the fruits. So they should find out what is the root. What is the root? So once if we get the root is there in our hand, definitely we'll get a fruits one day.
Okay, sir. Okay. Thank you, sir. And regarding the vigorous mobilization, the Maitland, that is your manipulation, the grade 5 will be coming under manipulation. So that is what is called as a vigorous movements. So while giving mobilization also, if you are going to give a vigorous movement or mobilization, so if does it falls into the mobilization thing, or it comes under the manipulation technique if you do the movement very vigorously? So what is the limitations we have to think over when we are going to give a mobilization at the grade 4 mobilization? Yeah.
Okay. The difference between here mobilization and manipulation is mobilization is in the within the patient's control. We can give the kind of oscillatory movements, and within that we can do. But manipulation is a sudden thrust. So sudden thrust movement, there is a limitation. Is if there is a door, we'll push a door is opening. It's a mobilization. We'll push a door is not opening. I'll apply the more extra pressure to open the door. This is manipulation. Same thing. When we do the movements taking place, yes, gentle movements, I'm repeating. So that is a mobilization. I can able to mobilize the joint. When I move, there is a stuck. I feel the therapist feeling there is some kind of resistance can be felt by the therapist. So, but if I overcome that resistance, then only I'll get a full range of motion. Then I have to apply a little bit of more force to cross the barriers, that's a manipulation.
Yes, yes.
That's the only difference between it.
Okay, sir. Okay. Thank you, sir. Thank you for replying for all the questions, and thank you for being with us, and thank you for presenting the session regarding the integrated manual therapy. Now I will give the forward the session to Asha Shanti to take over the session. Yeah, ma'am. Yes, ma'am.
Good evening, one and all. I, Asha Shanti, coordinator. On behalf of Sree Abirami Institution, I deem it a great privilege to express my vote of thanks on this session. First of all, let me thank the Lord Almighty for the completion of this session. So on my behalf, I extend my very hearty vote of thanks to our Honorable Speaker, Dr. G. Balaji, Principal, Narkund College of Physiotherapy, for providing insightful information and he's providing an excellent presentation on this topic today. So we must mention our deep sense of appreciation for his explanation on integrated manual therapy. It's my immense pleasure to express my sincere thanks to our Chairman Dr. P. Periswamy Sir, Sree Abirami Group of Institution, and our Board of Directors, Dr. Kundavi Devi Ma'am, and Dr. Sendil Kumar Sir, and Dr. Balamurugan Sir, Dr. Uma Devi Ma'am, and Dr. Sujarita Ma'am for providing such a great platform and constantly boosting us in every occasion. I also extend my sincere thanks to our principal, Dr. Jayabharati, for her valuable guidance and constant support in organizing this webinar. I also forward my thanks to our EDP department who stand behind us throughout the session for the completing the event successfully. Finally, I would like to thank our delegates and the students from various places who participated overwhelmingly and giving a huge response in making this event in a grand success. So once again, we thank you all for being with us in this evening. So with the due permission from our principal and with the speaker, I conclude the session now. Thank you very much.
Thank you.
Thank you, sir. Thank you for your wonderful speech, and thank you for all the delegates who have been watching this seminar, that is webinar on the YouTube. Thank you.
Thank you, ma'am. Thank you.
We will end up.
Thank you, sir.
Thank you. Thank you.